Hi, everyone. Thanks for joining us. We're so glad that you can join us today for our Let's Talk Menopause Myths and Facts. Really quick, I just wanted to make an announcement, just a small request. If you participants could mind just muting yourselves just for the sake of keeping things running smoothly, the audio not messing up. And then towards the end, if you have any questions, then feel free to unmute. But this is one of our first events, one of our first web seminars. So thanks for joining us. It's brought to you by Aqua Vitae, where we focus on empowering women and to take charge of their health and their wellness. Today's session is hosted by Maggie Ford, NFP, here in our Greenville location. Maggie specializes in hormone health, wellness, and she's just here today to break down common menopause myths that some may have questions about. But yeah, at the end of the seminar, we can go over questions if we have time. But if you have any, just feel free to drop them down in the chat box, the Zoom chat box. And just a quick reminder that this is for educational purposes and not specifically medical advice, just educational and entertainment purposes only. Each person, your experience is unique, and it can be addressed uniquely to you by visiting any of our locations in South Carolina and Georgia. With all that being said, I'm going to go ahead and welcome Maggie Ford to get started.
Thank you so much. All right, so this is one of my favorite topics. I got to be the first guinea pig out here as we start this kind of kickoff on doing some of these webinars. I'm really excited. Thanks so much for joining. This is going to be really informative. It's pretty quick. We're going to try to limit it to about 30 minutes. So I'm always available for questions. You're welcome to come see us in the future. But just to kick it off, first, I'm going to start by just kind of defining what menopause is, because this is kind of vague and it's an interesting definition. Technically, menopause is defined by 1 year without a menstrual cycle, which is interesting because people can go into menopause because of a medical necessity, such as a hysterectomy, and that can sort of take away that 1 year rule, obviously, if it's a forced menopause. So it's a very vague definition. And what's more important is that the symptoms often start way before I think people realize. So we're going to kind of go through some of the symptoms and talk about it. This is a great graph. It just kind of illustrates premenopause, sort of what the hormone fluctuations you can see in the first graph, what they look like. They're very normal, they're very stable. And then you get perimenopause, and that is often referred to as kind of this zone of chaos, or as you can see by the drawing, the hormones are all over the place. And this is what you start to feel. It's really interesting because menopause, the average age in the US is 50 years old. But what most people don't realize is this perimenopause, this crazy zone of chaos, can start 10 years before 50. So if you are 40 years old or in your late 30s and you start having symptoms, a lot of times people don't attribute it to menopause. The other thing that's interesting to know is menopause can be acceptable in the ages of 45 to 55. So even at 45, if you start in menopause, it's not really abnormal. It's maybe on the earlier side of the average, but it's actually still considered a normal age range for menopause. So when you walk that back, if you're starting and you go into menopause at 45, your symptoms potentially could start in your mid to late 30s. And that's what's wild. So we're going to go through some of the symptoms that you may or may not be attributing and just better understand what leads to this. And then in the last little picture, you can see postmenopause, and those hormones, that's when you stop producing. Your ovaries literally stop working. You run out of your egg supply, and then your hormones are flat. So it's just an interesting diagram to sort of show you through all the stages of hormones. So this is not all by any means of symptoms that you can start to experience in menopause, but you can kind of see vasomotor is the big one, right? So this is classic hot flashes. People feel like there's a fire inside them trying to burn and get out. And that is very descriptive and very visual. But the truth of the matter is that is not often early perimenopause symptoms. So if you're in your late 30s, you're in your early 40s, and you're starting to have symptoms, it's often not the first one that you see. It's classic, and it usually occurs later. Up to 70% of females will have hot flashes at some point in this journey, but typically not the first one. Usually they're softer things. And often what you'll find is one of the biggest ones is sleep. And so you'll start to see sleep disturbances. And you at first will just sort of blame it on you're just not getting a good night's sleep, or maybe your kids or things that are going on in your life. But it can be as simple as just not being able to fall asleep like you used to, and you're going towards melatonin and magnesium and trying to find all these tricks out of OPM, to having disturbances, meaning that you're waking up 3 or 4 times a night or even more and having trouble going back to sleep. So that's a big one, is the sleep. Then you get some brain fog stuff where you just can't remember things. And of course, things in your life can also trigger that, but that's a classic one. Another one, it's interesting, you can kind of lump it under the musculoskeletal, but things like joints can start to feel like achier and older and even dry. You'll see this, like a lot of women, one of the first symptoms, they'll go to their ophthalmologist because they complain of dry eyes. And that's actually a perimenopause symptom, interestingly enough. And you get skin and hair changes. You may see that your hair is thinning. You may notice that your skin is drier, that you're itchier. You may notice that you're starting to get more facial hair, or more like you're a teenager again and having some hormonal changes, all of these things. And then metabolic weight gain's a big one. So when estrogen starts to fluctuate, it can affect and disrupt insulin sensitivity. So insulin doesn't work as well, and you start to see weight changes. And then, of course, you get all the GSM, which is the genitourinary symptoms. So things like vaginal dryness, painful sex, more UTIs, and then irregular cycles start to happen. So all of these things are symptoms. Sometimes you don't realize they are. There's all kinds of wacky ones too, like ringing in the ears, vertigo, some of these weird things, frozen shoulder that people kind of complain about. But I would say initially, you're going to notice changes in cycles, changes in sleep patterns, and then often some mood changes, almost an increase in irritability and anxiety. Those are the classic ones I hear, is mood changes, sleep, and changes in cycles. Those are the first ones. And then you start to get some more of them that seep in, like weight gain, and then other strange ones. And then it goes into hot flashes. So this is all just to say there's a lot of symptoms out there, and a lot of times you don't realize that they're all related. So, all right, some of my favorite topics. These come up a lot. I've been in this world for about 7 years. I started in women's health, in labor and delivery. So I've kind of always come from that background. But I got lucky and walked into this sort of menopause world about 7 years ago, long before I was even having symptoms. And what's funny is now, fast forward 7 years, it's changed a lot, which is exciting. But I'm also starting to realize that some of my friends are starting to have these symptoms. So it's a whole new world for me as well. And it's kind of nice to be in it at the same time that there's a lot of changes going on in this world. So I just want to kick off by saying that there's a lot of people out there with megaphones that are making a large, I guess, or big impact in this world right now. And you will see it even right now. The FDA is trying to change the label on vaginal estrogen. The reason being is that it says currently that if you've had breast cancer, you can't use it. And the evidence has just sort of shown that's not true. So you're seeing that happen. You're also seeing across the United States a lot of legislation that's changing, that's requiring physicians to actually have training in menopause. So this topic is huge. It comes up all the time. And the thought is that my OBGYN or my primary care will be able to help me when I hit menopause. And it's not their fault, but the truth of the matter is that they often can't. So in the US today, only about 30% of OBGYN residency programs have any training on menopause at all. Not just some, but any. And in poll that came out recently, less than 8% of new doctors feel prepared and ready to train on this topic. So there's a huge deficit. It's changing, it's coming. But right now, the truth of the matter is that your OBGYN or your primary care physician may not be able to help you through menopause. It's just kind of where we are today. I think you're going to see this start to change even more. But I have patients that show up in my office all the time, and they say they went to their OB, and the OB says, well, it's just a normal part of aging. Just get a fan, wear layers, drink some cold water. And that's the old school training and old school thought on menopause. And the evidence does not support that at all. If your physician or your OB is telling you that, you need to find a new one because they're just not up to date on the current evidence-based guidelines. So this is a big one for me. It's just, unfortunately, they're not always going to be able to help you. And there is next one. This kind of goes great into this, segues into it nicely, because the myth is there's a blood test for perimenopause. The truth of the matter is there's not really a test. There's some data that you can collect, And remember, I said at the beginning, definition is 1 year without a period. That's a long time. So you can have symptoms and still be having periods, and you will until your egg supply is gone. You will continue to have cycles. It's just erratically. And the erraticness is what causes all these symptoms. So when you come and do blood work, there's a lot of factors that go into it. There's some labs that we can check that look at hormones to see if your body essentially is working really hard to ovulate. It's called the follicle stimulating hormone. So you can kind of get an idea of that. You can also look at estrogen and progesterone levels and get a feel for that. But what's wild and what people don't understand is if your body ovulated this month and everything worked out perfect and the stars aligned, you could look at some of this lab work and it could suggest that you're not in menopause. Conversely, you could have 1 month where your body just didn't get it right and you didn't ovulate. And this happens a lot in certain conditions like PCOS. And it can look like you're in menopause. So it also can look like that at certain times of your cycle. Like if you're just started a period and it's the first couple of days of your menstrual cycle, your estrogen levels are actually really low. So you can also look like you're in menopause, even if you're not. So the takeaway of this is you need to be seeing an expert that kind of knows and understands sort of all the nuances in hormones, because you'll see a lot of times a woman will go to their OB and they will do this blood panel test and they will quickly dismiss your symptoms and say, oh, you're not in menopause because you have estrogen and this one hormone that helps you ovulate is in a normal range. So this is where you kind of have to be your biggest advocate, especially if you're having symptoms that you're sort of asking for more blood tests or finding somebody that has a little bit more knowledge in menopause. The answer to this question is a little muddy. There's some testing, but a lot of it goes with also your history and your kind of your symptoms in terms of where you are in this journey of menopause. This goes back to, again, OBs often will dismiss you and say, look, it's a natural part of aging. You don't need hormone replacement therapy. So this is big. Any evidence and research that's come out in the last 5 years will strongly say that is not true. We know that women are 2 times more likely to have Alzheimer's than they are breast cancer. And the drop of hormones, particularly estrogen, increases our risk of Alzheimer's, dementia, Parkinson's. We've known for a while now that there are major changes when they look at MRIs on the brain in terms of when you drop estrogen, what it does into the brain. And essentially there's less blood perfusion, the brain actually shrinks. So there's a true cognitive, these symptoms of brain fog that people talk about, there is truly some evidence to support that there are changes at the brain level. So estrogen sort of helps protect the brain as you go into the next generation of life and next couple of decades. You have to remember that you're going to spend the majority of your life in post-menopause. I mean, you go into menopause at age 50. So there's a lot of years after that. And we want to do everything we can to protect the brain. So that's key for estrogen. The other big one you're going to see is risk of fractures. So studies have shown that 1 year after menopause and without estrogen replacement, your risk of fractures increases drastically. So the idea behind taking estrogen also helps with bone density and preventing osteoporosis. And then the last one is cardiovascular. So I always tell people, listen, losing menopause or losing hormones in menopause is, I guess you could argue, a natural part of aging. But just like if you lost your thyroid and needed hormone replacement to take the place of your thyroid functioning, it's the same concept in menopause. We're living longer. We're going into menopause earlier. You need to protect your brain, your heart, and your bones. Behind the scenes, that is the major impact that hormones has. I mean, there's a lot of symptoms that we talked about, like hot flashes and other symptomatic things, vaginal dryness, painful sex, that are important. But in terms of actual overall longevity and aging, you got to protect your brain, your heart, and your bones. And estrogen replacement does all of that. So that's critical. This is kind of back to, you don't need to worry about menopause until you're around 50. And the truth of the matter is it's just not true. I mean, symptoms start 10 years before that. So you can start to have changes to your mood and your sleep well before that. And there are things that you can do to treat perimenopause symptoms before you're actually in menopause. So this is why it's kind of important to advocate for yourself. You can see this here. This is a great illustration. It shows estrogen levels. It goes through starting at age 20. You see they kind of peak in our 30s, estrogen. And then estrogen starts to decline. And into our 50s, 60s, and 70s, there's no estrogen. And that's where we see the risk of Alzheimer's go up, cognitive decline, risk of bone fractures, osteoporosis, and then also after 50, cardiovascular disease. So increased risk of stroke and increased risk of heart disease. So directly correlated, as this graph shows or depicts, that the drop in estrogen has an impact on those things. HRT causes breast cancer. Okay, this is the hot topic. This is the one that always comes up. And this is the truth. The evidence just does not support this. There was a study in the early 2000s and 2002 that came out and really caused us to take a back seat in this. It caused a lot of stress, and OBs and primary care doctors stopped prescribing estrogen because of this. But the study was flawed. There is absolutely no absolute risk of increase in breast cancer that is correlated with hormone replacement therapy. Or if you could mute there's a little bit of background noise. Thanks, guys. You will see this come up time and time again. You'll see this topic come up a lot. The truth of the matter is that birth control actually has more hormones. I know this is shocking, but birth control pills actually have more hormones than hormone replacement therapy that you would get in menopause. And I would venture to bet there's nobody that's joined this webinar today who's ever been consulted when they were given birth control that there's a risk of breast cancer involved in taking birth control pills. So it's such a small amount. And the truth of the matter is that no correlation exists that it causes breast cancer. What we've seen is that some tumors that are related to this topic, or that in breast cancer, some of them like estrogen, and estrogen potentially feeds the tumor. So potentially could help it grow. Not all tumors, but some of them. But the truth of the matter is it doesn't cause it, it doesn't start it. So that's the biggest takeaway from this, is that there's no evidence today that shows that there is a tie directly with hormone replacement therapy and breast cancer. And truth be told, the incident rate of breast cancer is going up in younger women. And we see that if you look at it, it's about 0.5 to 1% every year that increases the increased risk of incidence in breast cancer. And if you look back at the last 20 years when they stopped doing a lot of hormone replacement, the risk continued to go up. So there's really no correlation. It's, if your provider is telling you this, then you need to kind of push back and ask them what they're looking at, what guidelines they're looking at, and advocate for yourself. You're seeing this a lot, that 5 years ago, even 3 years ago, if you had a family history of breast cancer, it would have been a no, that you can't start hormone replacement. And that's changed. It's changed because the risks of not doing hormone replacement in terms of cognitive, Alzheimer's, bone density, and cardiovascular is greater than breast cancer. So again, if you are being told this, or if your family history is strong in breast cancer, it warrants a good conversation. It does not mean that you cannot do hormone replacement, and you need to push your providers to sort of stay up to date on current guidelines. Testosterone is only for men. So look, I see men too. I predominantly see a lot of females. That's my niche. It's the area I like. But we do a lot of testosterone replacement in men. And this is a misconception. It's not true that testosterone is only for men. It's actually, you're going to find that in women, it's great for muscle density, bone density. It's also nice for energy and libido. But from a metabolic standpoint, it does help. When we age, we start to lose muscle mass. And this is critical for maintaining muscle and bone density as well, doing testosterone. Okay, and then you're going to see some of the benefits. Again, it's always about balance. That's the key to hormones. Too much or too little, it's always just the perfect amount. And so same thing with testosterone. You're going to see when you have low testosterone levels, it can affect libido, cause weight gain, loss in muscle mass, mood swings. Again, if you have too much, you can start to sort of swing more to a range where men have symptoms like extra hair, excess facial hair, deeper voice. The key is going to a provider that knows this and understands that you just need a little bit of testosterone. So again, just a small amount of testosterone to improve energy, bone density, to help with libido and weight, but not a lot, just a little bit. This one comes up a lot. I don't need progesterone. I don't have a uterus. Medically, this is true because progesterone opposes estrogen. And if you take estrogen, you have to take progesterone because it stimulates the lining of your uterus. But what you don't realize is progesterone is a GABA receptor. It's a calming hormone. And you'll start to see in perimenopause, you can have changes in mood, sort of similar to the week before your period starts. You often will feel an increase in irritability and anxiety. Sometimes people tell me they want to kill their husband. Not uncommon. And that is often the decline in progesterone. And the same thing happens in perimenopause. The truth is that that way you feel right before your period starts is how you kind of always feel in perimenopause, which is not fun. So progesterone kind of helps control that. It calms you down. It takes away irritability. It takes away anxiety. It helps you sleep at night. It really impacts that disruptive sleep cycle and the difficulty of trying to go to sleep. And the benefit also of progesterone is in this time of perimenopause, when the hormones are erratic and your cycles actually can get heavier, it's often because of the decline of progesterone. So if you boost the progesterone levels, you also can lighten your cycle. So you get lighter periods and then improved mood, improved sleep. So the answer to this is medically, you don't need it, but you want it and you will benefit from it. There are progesterone receptors throughout our whole body, brains, tissue, bone, everywhere. So you'll benefit from it. All progesterone is not the same. I'll just touch on this briefly. You do not want synthetic progesterone. It increases your risk of blood clots. It does not improve sleep. It doesn't affect your uterine lining. So synthetic progesterone, no, you do not want those. That's just a deal breaker. It has to be micronized progesterone. Increased risk of blood clots with HRT, again, not true. Only if you are taking certain types like synthetic or oral birth control or oral contraceptives, you will see they're contraindicated after 50 for this very reason. If you're doing oral estrogen, it goes through your liver and that increases prothrombin or clotting factors. So when you're doing bioidentical or hormone replacement in menopause, you don't want to do oral. So there's creams, there's injectables, there are patches, transdermal, there are things called pellets that go under skin. There are a lot of options, but you don't want it to be oral. That's the takeaway. That's kind of in a nutshell what I wanted to go over, just to kind of dispel some of the myths out there. Good news is we are across all of Georgia and South Carolina. You can see where all of the locations that we're listed at. You can see our Instagram at Aqua Vitality that you can follow, and you can shoot me questions or thoughts if you have something that comes up. I don't know if we have time to answer questions. Or are we going to try to do that in another? This is Eric.
Hello.
This is our marketing guru. Oh, there's one of them. Do you have to take progesterone with estrogen, or can it be alone? So the answer to that question is, if you have a uterus, you have to take both. If you don't, medically, kind of back to what I was saying, you can just do estrogen alone, but you miss the benefits of kind of helping with sleep, helping with mood, anxiety, and sort of alleviating some of those symptoms. So I think I kind of touched on that.
I guess take one question. If anybody.
Yeah. Anybody want to throw out any other questions that they want to ask? You have to unmute yourself. If not, that's totally fine as well. Yeah. So someone said, does family history play a role in determining when menopause begins? The answer is yes. Number one predictor of when you will go into menopause is your mom. So you may want to give her a phone call and ask her when she started menopause. It's something in the past that we didn't talk a lot about. And menopause is female in general in medicine. We don't get a lot of funding, a lot of money, a lot of research. You're seeing that change. There's a lot of legislation out there, but now it's starting to change. So go have a conversation with your mom. Ask her when she went into menopause. It's the number one predictor of when you will go into it. If your symptoms, okay, great question. If your symptoms don't interfere with daily life, do you still recommend hormone replacement therapy? The answer is yes, you 1000%. And this is where we see the risk of fractures that goes up, the risk of dementia, Alzheimer's, and then cardiovascular disease. So just think about it this way. If you start HRT or hormone replacement, it's sort of extending your longevity and continuing to protect predominantly your brain, your heart, and your bones. So even if you're not sort of symptomatic, there's some interesting research that actually shows if you are symptomatic, you actually have more risk of heart disease, or there's a greater risk that you are, I guess, in your future looking at some risk factors in terms of cardiovascular. So even with hot flashes, it shows like the women that have more severe hot flashes have more risk of cardiovascular disease. But just think of it as just like if your thyroid stopped working and you had to take Synthroid or some medication to treat that, you're sort of taking the hormone replacement to extend your longevity. And there's some really fascinating evidence that sort of supports that as well. So if you want to live longer, your goal is, even with they're not interfering in your life, you do hormone replacement therapy. That's the takeaway. But you will see as you get to 50 and go past there, even if you didn't have significant hot flashes, you will have other symptoms like vaginal atrophy, painful sex, more UTIs, all kinds of things that relate to that, as well as the common ones that we hear about today, like hot flashes. It's funny. I see some of my male colleagues that joined, which is, I love that because they're always trying to learn more about females. They think that we're very complicated, which it's true. We are. Yeah. So yeah, follow along on my Instagram. If you guys have more questions, we'll try to do some more of these. This session's recorded. So if you want to share it with anybody, that's great. It's going to be on YouTube. I think the biggest thing I would say to you is if you are having symptoms, they are normal. They start way before 50, and make sure that you find a specialist that's going to listen to you and somebody that's trained in menopause that can help you.